Yeah. They're things on that.
Guest speaker today, and this is a physician and educator that Dr. Bana has known for a number of years. I'm going to have Dr. Bana have the opportunity to introduce him to us. So very timely subject.
Thank you, Dr. Bucchini. We most of the time we invite the very academic faculty from various places, and we highly select clinical academicians or academic clinicians. Today we have one of the exemplary academic clinicians, Dr. Todd Mahr, who is combining the clinical practice to be at the cutting edge, as well as doing a lot of research and teaching and involvement in numerous organizations. He is currently the director of the Pediatric Allergy, Immunology and Asthma, and forgot where are you now? Yes. And I don't know how to pronounce Gundersen.
That's close.
Gundersen. That's a Norwegian. Although I lived in Norway for 2 years, I didn't hear this one, Gundersen. Right. That's great. He was a graduate from the University of Wisconsin Medical School. He went for a residency in Crosse Lutheran Hospital and the Allergy and Immunology Fellowship in Northwestern Children's Memorial Hospital. And he went back to La Crosse to practice until now for all these years. He has shown a great interest in national activities of the American Academy of Pediatrics, the American College of Allergy, and the American Academy of Allergy, and recently the American Lung Association. And I worked with him in almost all of this except the American Lung Association, but very special in the American Academy of Pediatrics, where we worked a lot on programs and we shared the podium together. And he's currently the chair of the section on allergy immunology of the American Academy of Pediatrics, and he's doing a wonderful job. He's a popular speaker both nationally and internationally, and we have good memories about that. So it is a pleasure to have you, Todd, with us here, and please come in to speak to us on the sinusitis and allergic airway disease, or one airway disease. And in appreciation of your coming, Todd, may I give you a small plaque for you for giving me a grand round.
Thank you.
Please welcome.
Hopefully this won't make too much. Can you hear me okay? All right. Thank you. It was indeed a pleasure to be here traveling down from Wisconsin. I ran into storms and had to reroute and drive 2.5 hours to a different airport, and it's been fun. But that's life. You don't think about that in Wisconsin. We had 5 days of no school this year, so the kids went later, and all 5 days were because it was below -40. It wasn't snow, it was that, and so our spring was definitely delayed. So I do speaking and some research for these companies, but we're not going to talk about anything that has any impact on that. We're going to review some sinusitis. We'll talk a little bit about acute and chronic sinusitis and the management options, and basically review the guidelines that came out is really what I wanted to do. And so we'll talk a little bit about that. But first, we got to talk about the nose and the paranasal sinuses. What are they? Well, for some people, it's basically a place to put your glasses and hold it, and that's really what it is. But it's a complex system. They're air-filled cavities at the entrance of the upper airways. They do a number of things. The nose air conditions, and for some reason I'm now realizing you need that here. And for us, it warms the air up in Wisconsin, and for all of us, it filters the air. For young boys, it creates boogers and it gives them something to do. So that's actually quite creative for boys. Girls don't generally do that. And it is actually something that mounts an immunologic response to allergens, to pollutants, and to other particles that really are protecting the lower airway. So our nose and our sinuses are very important. It's lined with pseudostratified epithelium with columnar ciliated cells. It's resting on a basement membrane. So it is part of the airway. A lot of people ignore the nose and the sinuses and think about the lungs, okay? And what we're going to talk about today is the sinuses and what happens with them and how they impact the children we take care of. I'm not going to go through the basic anatomy of it and the development. You guys can get that elsewhere. This is just to show you, again, the landmarks of where we're going to be talking about. And we're going to talk about sinusitis, but really, if you do any reading on this, rhinosinusitis is a term that's widely proposed in consensus documents by expert panels worldwide to use. Just like in our field in allergies, we talk about allergic rhinitis, and there's a big movement to really rename that and talk about it in the form of allergic rhinoconjunctivitis, because it includes both the nose and the eyes. But rhinosinusitis means it is the nose and the sinuses, because it rarely occurs. Sinusitis rarely occurs in the absence of rhinitis. Right? You almost always are going to have rhinitis first, and then you're going to end up with sinusitis. They are contiguous structures. They share the vascular, neuronal, and interconnecting anatomic pathways. So what is rhinosinusitis? It's an inflammation of the nose and the paranasal sinuses, usually 2 or more symptoms, one of which should be either nasal blockage, obstruction, or nasal discharge. So it's pretty rare to come in and say, I have sinusitis and all I have are my teeth hurt without anything else. That's something you might hear from adults. You won't hear it from children. But the guidelines are now saying you really need to have 2 of these symptoms, and one of them should be that nasal blockage or obstruction, or that feeling of some discharge, whether it be postnasal drip or running out of the front of the nose. Other symptoms definitely can be facial pain or pressure. You can have a reduction or a loss in smell, or both. Then we get into whether it's acute or chronic, and you're going to find differing opinions in the literature when you look at this. Acute rhinosinusitis clinically is defined as symptoms less than 12 weeks with complete resolution. So really the diagnosis of acute sinusitis we make initially with how long has it been there, and the fact retrospectively, when did it end and did it completely resolve? So that doesn't help us too much when we're in the midst of trying to make that diagnosis. But we're really looking at making that diagnosis early. And the problem is to have us all kind of take a step back from making the diagnosis too early and in a wrong case, basically. Chronic rhinosinusitis then is the symptoms usually lasting at least 12 weeks without resolution. So this is what we're going to review for the next 15 minutes or so. The clinical practice guideline for diagnosis and management of acute bacterial sinusitis in children 1 to 18. This was published in Pediatrics last year. It's an update on the 2001 guidelines. So think about that. The last guidelines on sinusitis were over 13 years ago. Okay, so this is an update on those guidelines. It focuses on the pediatric population, obviously, 1 through 18. They do not talk about subacute or chronic. It is basically acute bacterial sinusitis that they're dealing with. They don't go into the diagnosis specifically with anatomic abnormalities, immunologic problems or immunodeficiencies, CF, or ciliary dyskinesia. So it's the basic bread and butter pediatrics, what you're going to see in clinical care and what you're doing. So what they've done is they've done a few areas of change, okay? And I'm not going to go through all of the old guidelines. I'm going to highlight the changes because the changes are important. They've added a worsening course, and this is really interesting. So they've basically talked about, yes, you can have sinusitis, but you can have sinusitis that gets worse. And what do you do about that? So they gave some guidance on that. They do talk at length about the effectiveness of different antibiotics and what should be used. They also talk about an option to observe for 3 days in persistent infection. This is the one that's probably the hardest for most practicing pediatricians to think about. You're seeing a parent, they're in your office, they've got green snot running out, they've got maybe a little bit of a low-grade fever earlier, and you're going to tell them, you know, what we can do is watch for 3 more days. Right? We won't do anything. You may not see those people back. And so the real world comes in and they have some guidance a little bit on that. And then they do talk about imaging. We're going to review the imaging and how it's not necessary to identify or confirm the diagnosis of acute sinusitis. So what they did is they wrote this with key action steps. And so I put the key action statements in here, and I'll gladly share the slides with Dr. Bana if anybody wants these afterwards, so you don't have to take notes or anything. Clinicians really should make the diagnosis when a child with an upper respiratory infection presents with persistent illness. So what's a cold? So the common cold comes, you get rhinorrhea, runny nose, you get a little bit of a fever. The runny nose will usually go from clear to white to maybe even a little purulent and then back to clear. All right. The problem is all of our patients, parents, think that once it turns a little bit white and purulent, it's infected and they need an antibiotic. And that's the problem we deal with, okay? And they don't understand that that's the normal course of the cells shedding from the mucosa in the lining of the sinuses and the nasal cavity. So a persistent illness is defined now as nasal discharge or daytime cough or both, greater than 10 days without improvement. Not getting a little bit better, it's without improvement. They talk about worsening course. So in other words, a child, again, with an upper respiratory infection, so all of these are starting with URIs, worsening or new onset of nasal discharge, daytime cough, or fever after initial improvement, meaning they had a little cold, it starts to get better, and now it's getting worse, okay? And that fits in. And then there is a category of severe onset, okay? And these are the not too common, but do occur patients who present and they have high fevers, purulent nasal discharge, and it's pretty gross, okay? They're sick, and you won't really miss them when they come in because they really look sick, and that's severe onset. All right, so this is again what we're talking about. So there's basically this fever that can come on and then does go away. Respiratory symptoms are up, but what's out here? 10 days, okay? Now, those of you who are finishing your pediatric first rotation as third-year students, you should have gotten sick. If you didn't get sick, you should not receive a good grade, at least. I mean, at our institution, we grade you on how sick you get. If you get dehydrated with diarrhea, that doesn't count, that's stupidity, okay? But, you know, you're exposed to pediatrics and you're gonna get a cold, and this is what you're gonna have, a little bit of fever. What's the problem we deal with? Well, this is where parents are still sending their kids to daycare because they don't want to believe there's a fever, okay, and they don't want to do anything about it, and so they send them, and when you're talking a variety of other illnesses, that's why we stay in business, which is good, I guess. But it's not 10 weeks, this is basically 10 days, but you can see this fever is pretty short. The respiratory symptoms peak at about 3 or 4 days and come down. Now, if you had that worsening course, you would see symptoms come back up here, all right, and that's what you would see different. So, acute sinusitis, persistent symptoms. 10 to 30 days, no improvement. Nasal discharge, any quality, okay? Daytime cough, okay? Usually it's worse at night, okay? Most people have nighttime coughs, but with sinusitis, you're gonna hear about a daytime cough too, so they'll have both. Fever can be variable. Again, that fever came on initially, and now you're out 10 days, 15 days, 20 days, and usually you don't get a history of fever much anymore in that. And depending on the child, depending on how old they are, you might get a headache, you might get facial pain, you might get teeth hurting symptoms. It all depends on whether they can tell you that or not. Only 6 to 8% of children actually meet this criteria when you look at it, all right? Now, if you asked parents, how many of your children, when they have a cold, do they go on to have sinusitis, you're gonna probably get about 80% of them say, yes, those are my kids, but it's really 6 to 8% of children. So before concluding the child has sinusitis, what do we need to do? We need to differentiate between these sequential episodes of a cold. What do I mean by that? School and daycare is the cesspool of life, okay? And so these kids are constantly being barraged by all these different viral infections. And there is a number of different rhinoviruses out there, and then we've got a number of different other viruses out there. And so nothing says they can't be coming off one virus and they get another one. And you see these all the time in your continuity clinics, and out in the real world, we see a lot. That's what keeps urgent cares in business. But our job is to differentiate between those sequential episodes, kind of filter out, is this really a problem, or do we need to kind of talk about what else is going on for the child? And then maybe talk about some of the things that can lead to increased risk, like allergic rhinitis, like being in a family that smokes, some of the other risk factors. And then you need to establish that the symptoms are not improving. So it takes a good history that way. You have no lab, you have no real x-ray, we'll talk about that. For the severe symptoms, what are we talking about? Temperature greater than 39, and they have a purulent nasal discharge for at least 3 to 4 days. Not a little bit of junk. This is purulent. This is, you know, the kid usually is blowing bubbles out of their nose almost. They're really gross. Nobody's eating anymore. This is okay. And so a viral infection, it's usually pretty clear, it's thin. This usually thickens up and classically is more yellowish to a little bit greenish, okay? And that's how you can distinguish it, but it's not perfect. Again, you can't do a smear, you can't do a culture, you can't do anything that's going to help you out. So typically the worsening symptoms, you have viral symptoms to begin with, you get a little nasal discharge or cough, it starts to improve, and suddenly things get worse. Suddenly you have increased nasal discharge, you develop cough or both, you might have more of a severe onset of headache, and the older adolescent might be able to tell you that, and you get another fever, okay? Something's happened, okay? And if you think about it, you've gone from a viral infection to now most likely a bacterial infection. And that's basically what we're trying to differentiate with. So key statement 1 was basically talking about, all right, here's where sinusitis is, the background of what goes into it, and some of the history of the conditions that can make it worse. Statement 2A talks about not obtaining imaging studies, all right? Now, we were talking earlier that when I trained, it was basically, yeah, we were getting away from a Waters-Caldwell view and talking about limited CT scans of the sinuses, and if you're really going to look at the sinuses, do that. Now, the new guidance is basically plain x-rays, CTs, MRIs, or ultrasound really does not help you to distinguish acute bacterial sinusitis from viral URI, all right? So hold off on any type of imaging, all right? This gets complicated because a lot of parents want you to do it, or there's a lot of pressure that you feel to do something, okay? And you're maybe not comfortable saying putting them on antibiotics, so let's get imaging. So historically, we thought imaging was confirmatory. We were confirming our suspicion of sinusitis, so therefore I would feel good putting that patient on 10 to 14 days of antibiotic or whatever. But it's no longer recommended, okay? The continuity of the respiratory mucosa leads to diffuse inflammation during viral URIs. So a number of studies have been done, I'll review those briefly, that talk about the fact that when a kid's got a cold, it's kind of a crapshoot, so to speak, okay, as to whether you're going to see something that makes any sense. And you get a lot of controversy on whether images are positive or not. So a little bit of the history. In the 40s, they made observation regarding frequency of abnormal sinus radiographs in healthy children. So children otherwise presenting who were healthy had some abnormal radiographs. In the 70s and 80s, we noted that children with upper respiratory infections had frequent abnormalities of the paranasal sinuses. A lot of this was actually seen, they did some of the studies, we did one of these at Children's in Northwestern when I was there, on kids coming in for other reasons to the emergency room. And then we went into CT scans and looked at CT scans otherwise being done for the CNS of the skull, showing incidental abnormalities. MRIs are the same way. MRIs were becoming performed, they found 70% of them showed abnormalities of the mucosa in kids who were otherwise healthy and had no symptoms or complaints, yet their MRIs showed fluid in their sinuses. And this was a study that was done back in the 90s now. 31 young adults with a new cold. They were recruited within basically a few days of having their cold to have a CT of the paranasal sinuses. 87% of them had significant abnormalities of their maxillary sinuses, 2 with air fluid levels, okay? So the conclusion again, common cold was associated with frequent and striking abnormalities of the sinuses. So how does this help you? It doesn't. It really does not help you. It costs money. So this is what we're looking for, nice normal maxillary and ethmoid sinuses, okay? This is what sometimes shows up is inflammation, and you can't see, there's no fluid level there, but it doesn't mean anything. So these guidelines now are coming out and saying when paranasal sinuses are imaged in any way with children with uncomplicated URI, majority of them are going to be abnormal. So if you want something to confirm the reason for you to give an antibiotic, sure, get a CT scan. But it's going to cost money, it costs the healthcare system money, and it really is not going to help you. If you have normal images, you know it's not sinusitis, but abnormal images are not confirming your diagnosis and are not necessary in children with uncomplicated clinical sinusitis. You basically use your intuition and use your diagnostic skills and history taking. Key action statement 2B was you should obtain a contrast-enhanced CT scan of the paranasal sinuses and or an MRI with contrast whenever a child is suspected of having orbital or CNS complications. So we're no longer in the normal acute bacterial sinusitis patient. We're in the kid who comes in with a big red puffy eye and sinus symptoms, okay? And in those patients, that's what you should get. What are you looking for? What are the complications of sinusitis? Orbitally, it's sympathetic effusion. That's an inflammatory edema. In my era, we called it a preseptal or periorbital cellulitis, okay? It's an inflammation of the tissue surrounding the ethmoid sinuses classically. It is not spread of the infection necessarily into that area. There's subperiosteal abscesses, there's orbital abscesses, orbital cellulitis, and a cavernous sinus thrombosis is what you're kind of looking at. So these are the children that you see. They come in, they've got this nice red puffy eye, okay, and that should worry you, okay, this guy. Okay, that's a sinusitis presentation that you should be concerned with. Okay, the things you're looking for are proptosis, either anterior or lateral displacement, impairment of extraocular movements, I'll show you that in a minute, loss of any visual acuity, depending on whether they can open their eye or not, and then chemosis or edema of the conjunctiva. So here you see him looking up and to the right, up and to the left, and this eye is not tracking. Okay, so you can see the redness of the eye. And what you see here is the abscess he has, and it's impinging on the muscle, which is why the eye is not moving, okay? And you can actually see there's the proptosis that's occurring with this case. So that's when you get imaging, okay? The CNS complications then of acute bacterial sinusitis that worry us, very severe headache, photophobia, seizure, any focal neurological findings, and then you're thinking subdural empyema, epidural venous thrombosis, abscess in the brain, or meningitis. All right, so that was diagnosis a little bit, a little hesitation on making the diagnosis. What do we do with imaging? When do we use imaging? How do we manage acute bacterial sinusitis? So they've got a couple statements in there. Clinicians should prescribe antibiotic therapy for acute bacterial sinusitis with severe onset or worsening course. So what they're telling us is, you've got a child, you think they've had a URI and now it's suddenly getting worse, okay? Or it's somebody who comes in and fits that 3-day kind of window of high fever and really thick, gooey junk that's horrible. That's when you could use an antibiotic. Then they go on and say clinicians should either prescribe antibiotic therapy or offer additional outpatient observation for 3 days to children with persistent illness. That's the one that a lot of us are going to kind of go, oh yeah, really? That's going to not be the easiest thing to do, all right? So for persistent symptoms, you want to start antibiotics as soon as possible, okay? But on the corollary, they're kind of saying, maybe for 3 days you could just watch again and begin antibiotics if the child does not improve or worsens at any time. Now the question there would be, and a very good study based on these guidelines would be, set up in an outpatient basis, if we offer patients 3 additional days and write them the prescription for the antibiotic and say, wait 3 days, how many of you think are going to start it? A lot, okay? And so the study's not been done, but I think that's just human nature that, you know, no mom is going to sit there with this prescription for amoxicillin or Augmentin in their hand or already at the pharmacy and wait 3 more days. Now, you're going to have some that will, but it's going to be difficult. And this contrasts with our 2001 guideline, okay? So it acknowledges that ABS, or acute bacterial sinusitis, is a bacterial infection, but what's really being shown is that spontaneous resolution is really pretty common, okay? 10 days is a guideline. There's going to be really no likely any harm in allowing 3 more days is what the expert panel was kind of feeling, that, you know, we drew the line at 10 days. Now they're saying, you know, maybe plus or minus another 3 days might be worthwhile. It does emphasize antibiotic use as soon as possible in severe or worsening. So it's not saying every child you think has bacterial sinusitis, you should wait for 3 days. It's saying you got this subsection of patients who have severe or worsening illness, definitely you need to start. We'll talk about what with in a minute. But they're kind of saying maybe hold a minute, maybe step back a minute. So if they're uncomplicated bacterial sinusitis with coexisting illness and it's severe or it's worsening, they need an antibiotic, okay? However, if it's just really persistent and hanging on a little longer, you could decide to do the antibiotic or you could do additional observation. Now, this is where the nuances of medicine come in, like the persistence of the parents, the fact that child is going on a cruise with mom and dad, or going to be flying somewhere, or starting a new school, or it's a teenager who's starting school or going off to college. That might influence what you do. If it has orbital or CNS complications, they all need antibiotics, okay? If there's another bacterial infection you see, whether it's an otitis or a pneumonia or something else, they need antibiotics. And what antibiotics? I'm going to hit on this. There we go. So amoxicillin is still what's recommended with or without clavulanate, and that's the first line treatment. It's not the cephalosporins. It's not Zithromax. And it basically is, when you decide to treat, it's amoxicillin as first line, and we'll talk about clavulanate. Why? Okay. Well, they're still doing microbiology of acute sinusitis. So it's gleaning most of it from acute otitis media. Why? Because we don't really get biopsies very often of the sinuses. Okay. They're extremely difficult to do. Okay. The ear isn't the easiest, but you can usually get some good otolaryngologists who will tap the ear for you, and you can get good microbiology from that. The sinus is extremely difficult, okay? How many have ever, there's a lot of you here, but how many have ever seen an actual percutaneous puncture of the sinuses? Not fun. Bone crunches, and it's just, ugh. So doing that in kids, not many studies were really done, right? But what they did find when they did some of the original studies is that really mirrored what they were finding in acute bacterial otitis media. So similar pathogenesis, similar pathophysiology, and you can see that the ear and the nose kind of tend to be together. Here's in some tracking, looking at the otal pathogens that are seen. Yellow is strep pneumoniae, and you can see kind of a up and down. And what is this influenced by? It's influenced by antibiotics available, but it's more influenced by the vaccines that we now are using, okay? So in 2013, strep pneumonia, about 15 to 20%, H. influenzae, 40 to 50%, Moraxella, 10 to 15%, there's some strep pyogenes, and 25% were sterile, all right? That's kind of been pretty consistent data, all right? Now, whether you're not actually culturing for what's causing that infection is debatable, but it's something to always keep in the back of our mind, which is why doing nothing sometimes works. Resistance changes. You need to know your own susceptibilities here in the Shreveport area. It's definitely going to be different than for me up in Wisconsin or New York or Philadelphia, okay? And that's why the biograms are sent out, and you can get that information. But it can be M. catarrhalis up to 100%, H. influenzae anywhere from 10 to 70%. But it's still, amoxicillin is first-line therapy. It's 45 milligram per kilo per day in 2 divided doses. If there's a high prevalence of penicillin-resistant strep pneumoniae in your area where you're practicing, then you may want to consider the 90 milligrams per kilogram per day. So you've got not the lower dose, but the 45 or up to the 90. It is ineffective against beta-lactamase producing bacteria, so you have choices. You can go with a drug that is a little less resistant, and that usually is combining amoxicillin with the clavulanate. So if strep pneumoniae remains low or continues to decrease, or H flu remains high and continues to increase, we might be switching to augmentin, okay, or amoxicillin clavulanate as our dosage and what we recommend. So know your area. When you go out and practice after your residency, you need to know what's going on in the area, and that will directly impact you. And then there's also guidelines, and I didn't put them in here, on what about some IM dosing and what do you do in the allergic patient. Key action step 5A is what you should do. The clinician should reassess initial management if there's a caregiver report of worsening or failure to improve within 72 hours. That magic 3 days. So you either can give them the 3 days, you should be in touch with them, or if you do treat and they're still worsening or getting basically not better, then you should reassess what you're doing. Most patients with bacterial sinusitis are treated with appropriate antimicrobial, respond within a couple days. So we can rest assured that you get pretty good tissue penetration if you use an appropriate antibiotic. What's not an appropriate antibiotic? Well, Zithromax doesn't make it into the sinuses very well at all. It's a lousy choice for sinusitis. The problem is it gets used a lot in the outpatient setting, All right, it's almost the drug of choice in an outpatient type setting, and azithromycin is not good for sinusitis. Again, worsening means progression of signs and symptoms, and failure to improve means they're no better or no worse. All right, and then so if worsening symptoms or failure to improve, clinicians should change antibiotics or initiate. So if you have already put them on something, low dose amoxicillin or 45, you may want to switch them to the augmentin choice, amoxicillin clavulanate. If you've not chosen to treat them and they're getting worse, you need to initiate antibiotics. So that creates a little conundrum for us as practitioners is who's liable if you basically say, I'm going to wait 3 days. You have to put this into your system to make sure your nurses are calling them, okay? Or you better document with that you've actually told the mom or dad to call you if they're not getting better. So a lot of this is involved, whatever system you have in place. All right, at 72 hours, whether or not antibiotics are used, you need to have that system in place to either add antibiotic or change. So the guidelines say this. There's now published guidelines that are out there that say this. So as residents starting out in practice or in your continuity clinic, you need to make sure you're covering this if you decide not to treat. So you have observation, okay? If you decide to observe only, if they're worse in 3 days, probably you'll do amoxicillin plus or minus clavulanate. If there's no improvement in 72 hours, okay, you're initiating that antibiotic. Okay? If they have initially amoxicillin, you're going to up them to less resistance. And then basically, if you've already started them on the amoxicillin clavulanate, you've got a variety of options. Clindamycin, cefixime, levofloxacin, it depends on what you want to use and what you feel comfortable with. What about adjuvant therapies? Okay? Now, I'm an allergist, immunologist. I feel very comfortable with talking about allergic rhinitis with patients and asthma, and we tend to use the nasal steroids quite a bit. But when you look at the data, and there's been a Cochrane review just recently on intranasal steroids, it's mixed, but it's not very strong data that the intranasal steroids will do much for a patient. The feeling was, if we go back to the picture of the sinuses, that if I can use a topical steroid in the nose, I'm going to open up the ostia to those sinuses and you'll get better drainage, so to speak. In theory, sounds good. In practicality, there were limited studies with a number of design flaws that really led to the fact that you can't really draw concrete improvement always in the use of an intranasal steroid. This is going to be touchy. Why? Because now intranasal steroids are available over the counter. There's a product, triamcinolone, over the counter. And that was one of the questions the FDA had. Would consumers be able to tell the difference of when to use an intranasal steroid? And the intranasal steroid over the counter is approved down to age 2. It's pretty intriguing. Definitely antihistamines have been shown orally not to give you any benefit. We all like to talk about intranasal saline. Now this is not the squirt that's shown up here. This would be saline lavage, okay? And if you talk to anybody in otolaryngology or allergy, we'll be promoting it. Okay, you can't watch Dr. Oz or Oprah and not see neti pots and other things going on. But when you look at the data, again, there was a Cochrane data review that kind of was mixed, saying, maybe, maybe not. I kind of fall back on what does the patient want to do. You're talking younger children, you're really not going to get them to do that. You talk older teens, and we take care of adults too. They usually will, and it'll make them feel better. And decongestants really don't do much. So, the summary of the guidelines are to use stringent criteria to diagnose sinusitis, avoid obtaining images. The antibiotic of choice is amoxicillin with or without clavulanate. High-dose amoxicillin plus clavulanate for resistant, that's the most comprehensive. And adjuvant therapy is rarely indicated. Chronic rhinosinusitis. So what about chronic rhinosinusitis? In pediatrics, we don't talk about it much. In allergy, since we do adults and kids, we see this a lot, okay? And it's talked about as persistent inflammation of the nose or sinuses anywhere from 4 to 12 weeks. It depends on the author. They talk about acute, like we just talked about, for the 2 to 4 weeks. Maybe a 4 to 12 weeks is a subacute or early chronic, and then persistent or late is 12 weeks or more. So acute is usually consistent with bacterial infection. That's the data you'll read on chronic rhinosinusitis. Subacute, you're in no man's land. You're kind of in this, it depends on the patient and what else they have underlying it. Chronic Usually, it's felt to be either an unresolved subacute infection or it's just chronic inflammation, right? And that's what you have to deal with, and you somehow have to fix that. So the key questions in chronic rhinosinusitis we're dealing with is there currently a bacterial infection? Even though this is chronic, it's been going on and off for 12 weeks, is it bacterial right now? Will an antibiotic help? Is there underlying eosinophilic rhinitis? Is this an atopic disease? Are there underlying abnormalities, all right? So are there polyps, okay? Classic board question that will be on your PEDS boards is you basically are looking in a child's nose and you see polyps. What's the next thing you should order? Sweat test, all right? Now that CF is screened neonatally in all 50 states, you might say, well, you shouldn't have to. That's the wrong answer, okay? Because screening's not perfect, and there are some reports of missed CF with screening, all right? So you got to think about CF or an eosinophilic or non-allergic. And then, is it an osteometal complex compromise? Is there something going on in that osteometal complex? And then, does the clinical picture suggest some type of immunodeficiency? So, if it's persistent subacute and there's no improvement, you have to think, maybe they're resistant to the antibiotic. Maybe I have to do something a little bit different, okay? Maybe there's altered penicillin binding proteins, beta-lactamase production, maybe it's a macrolide ribosomal methylation. What's going on? Why didn't the antibiotic work? Or maybe there's poor drainage through the sinus ostia, and this is where you do get into what's the anatomy like, okay? Is this a teenage athlete who's had their nose broken twice, okay? All right, and that's going to impact things, all right? Is there something else that went on in this child? Was this a kid who, had a little bit of behavioral health problems and shoved 42 crayons up his nose in the first 5 years of his life? Well, that will damage that up there. All right, I've seen that once. It wasn't 42, it was about 8, but he was a persistent little shover and liked to do that. Significant allergic rhinitis. They have allergic rhinitis, but they've never gone in to get it treated. They just have put up with the snorting, the sniffing, the congestion forever. Or is it other viral illnesses? Then you're going to have these patients that are recurrent, acute, or subacute, the ones who come in and say, every cold turns into a sinus infection. What do I do with those? They're really in the chronic rhinosinusitis category, okay? What you're going to look for is, ideally, you want them to be asymptomatic for at least 4 weeks or so in between, okay? Ideally, they should be ones who don't have eosinophilic rhinitis and don't have anatomy problems. And these patients, then, you may want to look at their humoral immunodeficiency panels and find out. Now, if it's just this colds become a sinus and they don't have recurrent ear infections, they don't have bronchitis, they don't have pneumonitis, pretty unlikely. Anatomic issues, refer to your ENT colleagues or whoever does rhinoscopy, okay? This would be out of the realm of what the first part of my talk was, and we move into, this is where imaging will help you, okay? Coronal sinus CTs to lay a roadmap of what is that anatomy like. Again, nasal polyps, the osteometal complex, and adenitis. Okay, so adenitis is something that is talked about a little bit. There definitely is kids who have a chronic, subtle type infection of their adenoids that goes on. Okay, we're seeing it more now again because less TNA is done. We went through a period of time where almost every child had a tonsilloid or had their tonsils and adenoids taken out. Now they're done separately usually, and usually you don't have the adenoids done as much. And so you have to keep that in the back of your mind. Immunodeficiency. This talk isn't about that, but bottom line is, if you're thinking this child may not have a normal immune system, there are some key things you might want to look at, and I'm sure have other great lectures here about what do I do, where do I look at, and what order do I kind of do this immune workup. So with that, I tried to end before that big ugly black arrow up there that said lecture ends, and allow some time for questions. And hopefully it was an overview. You've got the reference, and again, I'll get the slides to Dr. Bana for anybody who wants them. They're all yours if you would like them. And I want to thank you for having me here. Questions?
As expected, Todd, you gave us a superb lecture that we benefit from. Thank you.
Thank you.
Any questions for Dr. Mahr?
Or I'll pick on the residents.
Well, no, I would pick on you.
Oh, okay.
If they don't ask you, I will. So save him from my hand, please. Go ahead.
This is a man who got me to eat brain in Egypt. So, I mean, he's pretty
Well,
persuasive. It wasn't,
You enjoyed the visit.
I enjoyed the visit.
And you were
The french
offered-
fries that came with the brain were okay.
You were offered the most expensive delicatessen
I
and
know,
the best
it was the
place.
most expensive there was. I was very impressed when I landed here in Shreveport. I saw Sammy's Town, this big building downtown, and I thought, oh my God, he has this whole building and casino. Now I know why he's here. But then I realized it's not Sammy's Town.
Comment about topical antibiotics for chronic rhinosinusitis.
Right, and I didn't get into all of it. I mean, the chronic rhinosinusitis talk could be two of them, all put together with, when you start looking at biofilms and a variety of that data, it's really intriguing. There's been some very nice published articles on that. And they're looking at topical mupirocin and other antibiotics in some of those cases. And I think when you're truly dealing with a true chronic rhinosinusitis that's persistent, that you're having problems with, that's one of the things you have to think about, okay? And then there's actually some data that's very unique where they'll actually put a catheter up in the maxillary sinus and people will basically irrigate their sinuses out. I've not done that. I can't find somebody who's willing to do it, but it sounds intriguing. Or nebulized. They'll do a nebulized sinus type antibiotic and it makes some sense.
Any preference which antibiotics to control?
It all depends. I think that's where you really, the antibiotic of choice in that case, you need to look at what's going on within your system, and you also need to probably get some cultures on that patient specifically, because you don't know if you're dealing with possibly a Pseudomonas in that case, or possibly fungal. So I would, before I would do that, I would want to get to my colleagues who can actually do a good sinus culture, okay? But you're gonna have to put that patient through it because they have chronic. So you can reasonably say, this is why we're going to do it, and they're usually suffering. And they'll, you know, we're talking more adults here than peds. Yes?
How do you decide between like a current viral infection versus a treatment failure in acute sinusitis?
Usually that time period in between, that's a great question. So how do you decide between this person just has bad luck of having a viral infection, another viral infection, another viral infection, or that worsening case? And that's where you have to look at fever and the discharge and how much time in between. And what would help you a lot is they would say, I got better, I was better for 2 days, and now I'm worse. Then you can think more of bacterial sinusitis, whereas they were better for 4 or 5 days, and then they got sick again, more likely that it's another viral illness. It's a great question. But that's real world practice, and that's what hits you. So Gundersen, I didn't tell you about where I practice. So Gundersen Health System is a 600 physician, 6,000 employee, multi-specialty clinic. It's kind of like Ochsner. We have 23 branch clinics in Wisconsin, Minnesota, and Iowa. We're right on the border. I live on the Mississippi River, basically, and so I go over to Minnesota and go over to Iowa to practice. So it's a large multi-specialty group. That's what we grow a lot of big multi-specialty groups. We're an hour from Mayo Clinic, yet we're still doing quite well. But it's nice to know about what are the other practice opportunities out there. All right. Sammy, question? Or?
Yeah. You can tell us about the upper and lower respiratory tract. Many people just ignore the upper,
Right.
and they come for asthma.
They come for asthma and not maligning pulmonologists, but pulmonologists will think that the nose is just a conduit to put through to look at the lung. But Sammy's right. There's a whole bunch of data on the upper and lower airway and how they link together. And I tried to imply that at the beginning. We'll do a better job next time, but basically they are interrelated. I mean, when I talk to the medical students and that about asthma, it's what are the comorbid conditions, and one of them is sinusitis, okay? That definitely, if you control people's allergies and sinuses, their asthma will be easier to control, right? So it's not something to ignore. It's not symptomology to ignore. It's something to really deal with. So, thanks. All right, thank you all for providing this 90-degree weather for me from Wisconsin. I appreciate it. Thank you.